Dear all, it is great honor for me to have such unique opportunity to appeal to you directly through this vain week.
Greetings. It's a real pleasure for me to be asked to present to all of you around the world, wherever you are, about the call to action for Vain Week.
Having a leg wound means never having a good day, but by working together, the leg
Trabajando juntos en la Fundación DWIN,
prevention of venous and lymphatic health problems by supporting the International Health Awareness Week. Remember, Vain Week, April. Please come and join us.
Estimados amigos de habla hispana, son las enfermedades venosas.
Dear Spanish-speaking friends, these pathologies are underdiagnosed, and lymphedema is the hidden disease. Let us disseminate the importance of these diseases and the need to be treated during this week, Vain Week.
أهلا وسهلا بحضراتكم. من 5 ل 11 أبريل هيكون الأسبوع العالمي للصحة، وكمان هيكون بنقدم الأسبوع العالمي للأوردة. حقيقة الأوردة بتمثل مشكلة كبيرة، خصوصا المضاعفات الدوالي ومضاعفات الجلطات المتكررة التي ممكن أن ينتج عنها القرح الوريدية، ودي بتؤثر جدا في مجتمعاتنا اقتصاديا واجتماعيا. فإحنا بندعوكم للأسبوع الأوردة من 5 ل 11 أبريل. ابقوا معنا. Vain Week.
Goeiedag. 5 tot 11 April merk internasionale aardweek. Ons hoop om bewustheid te skep van diep aardtrombose, bekkenare wat pyn in vrouens veroorsaak, en geswelde bene van die swak erkende toestande van lymfedeem en lipödem. Ons hoop om julle almal tydens Vain Week te sien.
Halo, saya Dr. Liu daripada Malaysia. Pada 7 hingga 11 April tahun ini, komuniti Phlebogy akan mengadakan satu minggu Vena Limfa. Pelbagai aktiviti akan dijalankan. Saya menyuruh kepada semua warga Phlebogy dan Vascular Society supaya menyertainya dengan bersungguh-sungguh. Terima kasih.
Dal 5 all'11 aprile si festeggia la settimana della salute. È importante però anche celebrare la consapevolezza della patologia venosa e linfatica. Patologia venosa, una delle prime cause di morte prevenibile. Linfedema, un'epidemia definita nascosta, troppo spesso misconosciuta. Quindi vi aspettiamo a braccia aperte per la Vain Week.
प्यारे दोस्तों, आपको पता है कि विश्व में हेल्थ को लेकर हम एक वीक सेलिब्रेट कर रहे हैं 5 से 11 अप्रैल। तो हम चाहते हैं कि उसी दौरान जो नीले रंग की खून की नसें जिनको हम वेन्स बोलते हैं उनकी बीमारियों को, और लिम्फेडिमा जो वाइट रंग की खून की नसें होते हैं उनकी बीमारियों को हम वीक में सेलिब्रेट करें और उनकी नॉलेज बढ़ाएं। बिकॉज वेन्स की बीमारियों से हमारी जो क्वालिटी ऑफ लाइफ है उस पर बहुत फ़र्क पड़ता है। अगर हम इसको एजुकेट करेंगे ड्यूरिंग दिस वीक, ऑल द पब्लिक एंड द डॉक्टर्स, उससे हमारे पेशेंट्स के लिए बहुत बेनिफिट होगा। तो प्लीज़ ऑल ऑफ यू हमारे को ज्वाइन करो वेन वीक 5 to 11 में। थैंक यू।
各位同道们、朋友们，大家好。静脉淋巴疾病是非常普遍的疾病。我们在今年的4月5号到11号会有1周的静脉淋巴活动，谢谢大家踊跃参与 Vain Week， 谢谢。
placer invitarlos a participar activamente de esta.
It is a pleasure to invite you to participate actively of this Vain Week. Your vein, your life. We'll meet during the Vain Week.
It's April 5, so it's finally time to say benvenuti to the Vein Week, in this case to the Italian initiative that is dedicated to the health professionals today. As you might know, all the days of this week will be dedicated to different audiences, and there are more than 250 events running at the same time, for which it is my true huge honor and pleasure to broadcast from Italy today. Today we will focus on health professionals, tomorrow on public awareness, on Friday on multi-specialty, and on Saturday on social engagement. Today we are going to enjoy simultaneous translation in English, Spanish, and Italian. So I remind you to select the language you prefer and to eventually mute the original audio. Everybody is welcome in making whatever question in the question and answer box. They will be all answered live if possible, or in written form in the next days and uploaded in the platform. Why creating a Vein Week? Well, we know that basically we have the chance of flipping a coin in front of our patients and having to deal with venous or lymphatic disease. According to the literature, we know it's an extremely frequent cause. And we also know that it is related to the leading cause of preventable death, venous thrombosis. That I like to point out indeed is preventable. So it's a call to action we should all take as the one of the hidden epidemic that indeed is the lymphedema. For this reason we are today, and we could not be more honored than today in having the huge giants, Professor Caprini and Professor Lee, in representation indeed of the vein ward and of the lymphatic ward. Nothing would have been possible without the teamwork for which I am more than honored, for which I'd like to deeply thank the steering committee that started this project with representation from all the continents, including gender representation, of course, and all the 100, and there are already more than 14 actually developers who have joined this group effort from all the continents. There are, as I was saying, more than 250 events already uploaded, so today and in the next days of the week, you can join the platform and choose the ones you prefer. I'd like to deeply thank the ones who have made this possible through unrestricted grants. So a special thank to Alpha Sigma, Medi, and Philips for their support to this not-for-profit initiative. As always, I'd like to thank the ones who have made all the VWin activities possible, starting from Professor Bottini. Oscar?
Thank you, dear all. Once again, thank you for being here with us on this educational project, Vein Week.
Thank you so much, Oscar. Now, Vein Week indeed is a week, so we cannot pretend to have everybody always active during working days, and the same Professor Chi is now in clinical hours, so he will try to join us for the answers to his presentation.
Good morning, good afternoon, good evening. Today we have a great program focusing on superficial venous disease as well as perioperative management and lymphedema therapy. Please enjoy.
And we deeply thank Professor Chi. And since we are transmitting from Italy, I will now exit my English channel and go back to my original Italian channel, because I like to present, I have the sound of the translator, but it's okay. So I like to introduce Professor Valle, che è una persona splendida, però io, scusate solo un secondo, visto che comunque siamo anche tra amici.
And now I'm in English. Sento una traduzione in italiano e perciò devo parlare in italiano.
So let me go saying that we made an exception in introducing also Dr. Valli in the opening remarks, because it's always not just where you go, but also who you are traveling with. And Paolo Valli is for sure a colleague that makes every travel a pleasure, professionally speaking. He really committed himself in the Vein Week Italy project, so I think it's right to have his word. And since he's here, I think, Paolo, you can also give a word live if you want. Paolo?
Buonasera a tutti, grazie dell'invito.
Good afternoon, everyone. I thank you for your invitation, in particular Oscar, Willie, and Sergio. I'm honored to be here today for a beautiful initiative, I must say. You have to change your channel to Italian, Dr. Paolo, if you wish to speak in Italian. Good afternoon, everyone. It's an honor and a pleasure to be present here today for this initiative that is one of the most beautiful initiatives I have participated in. So I wish to thank Oscar Bottini, Willie Chi, and particularly Sergio Giannesini. Sono tutte iniziative interessantissime. Very interesting initiatives for Vein Week.
Thank you so much. And we were discussing before with our giant Professor Caprini about the fact that better sometimes is worse than the good. And indeed, another saying we have is that complications are happening just to the ones who are doing things. So I ask for some forgiveness if we have some technical problem with the translation, but we are really trying to connect the different languages together. But not just languages, literally also countries, because today is quite an historical day, because the very last meeting we attended in person from Costa Rica was indeed Flebo Latam. And indeed, today we are broadcasting to the first, up to my knowledge, in-person meeting that is going on in this moment in Costa Rica. So I see we have Dr. Lorena Grillo with us. I just say hi. I don't know if you can speak live from there. Yeah, that's okay, so you will speak live.
Yeah, lo voy a hacer en español porque estoy en el canal en español grabando.
Okay.
Okay.
Yes.
Primero, un gran saludo a
First of all, my greetings to all of you. Thank you very much for being with all of you in this great journey around the world, sharing knowledge and promoting awareness of venous and lymphatic disease. It's been it's a challenging times that have brought to life new teamwork projects that have been very interesting, like the Vein Achieve Pop and now a leader in innovation, Vein Week. There is no doubt that this week has changed all paradigms, and I would like to thank for the possibility and continuing to urge to invite all of us to educate our population so that we can have a positive impact on the quality of life of our patients. Thank you.
Thank you so much, Professor Grillo. And now we fly all the way to Egypt for another person who showed a great commitment during the Vein Week Egypt, Professor Hussein. I see that you are here, Ahmad, but I don't see your camera, so I suppose you have some connection issues, so we will go with the video of yours.
Good afternoon. I'm Ahmad Hussein, and on behalf of the African Federation of Angiology and Vascular Surgery, the vascular surgery departments in both Aswan and Ain Shams universities to which I belong, and the organizers of the Egyptian Vein Week, I would like to thank the VWIN Foundation, Professor Sergio Giannesini, and Drs. Oscar Bottini and Willie Chi for the kind invitation to witness and be part of the Italian Vein Week. In fact, the simple truth is we were inspired by the Italian model because what happens in North Mediterranean resonates over here in the South Mediterranean. So we decided from our side to celebrate the Egyptian Vein Week in the beautiful city of Aswan, southern Egypt, on Thursday, 8th of April, where we would be starting awareness campaigns, flyers for the families of the healthcare providers, bringing focused and selected amount of young vascular fellows, and we will go live on national TV on the same day to highlight the importance and sometimes seriousness of veno-lymphatic diseases. We managed to bring over the health authorities, the NGOs, and of course families of the healthcare providers, which represent just a sector of the community. I do wish you the best of luck. And by the way, we cordially invite you to join us next Thursday at 10 a.m. Cairo local time, which is, I think it's the same as the Central European time right now. We are GMT +1. And you can see over here simple information in Arabic language, of course, to highlight what we are talking about. This will be distributed and handouts for the families and for the junior young vascular fellows. And you can see over here the logos of the different participating societies and scientific bodies, including, of course, the VUN Foundation. Once again, I wish you the best of luck, and thank you for joining efforts in the middle of the pandemic. Grazie mille. Ciao.
And we thank Professor Hussein, and indeed we wanted to stay in Egypt because Egypt is where everything starts. And I have to say that there is one Egypt and there is one Cleopatra of phlebology, that is Professor Wassil Atta, who not only starts things, but also put them forward and forward and forward, for which I see that Wasila is here. I guess maybe you want to say a word live since you're here.
Yes, thank you, Sergio. I cannot take the floor without congratulate our dear friends, now family, really family, and the pillars of the VUN Foundation for such a great achievement. It's a tremendous source of honor being among you and among such a stellar faculty and international experts of our passion, the vein and lymphatic science, to inaugurate the Vein Week. It's a mega project with multiple aspects and objectives, and it has been a long journey with multiple wonderful relays of preparations, of logistics, and since early steps of the steering committee, which I truly honored to be part of it. Now we are here, we succeeded, we are gathered together and stick together from all four corners of the globe, demonstrating that we are here to serve our passion for the benefit of our patients and our young fellows. And no matter the distance is, no matter the languages are. And I'm delighted to end my message with the quote by Albert Einstein saying, "It's the supreme art of the teacher to awaken joy in creative expression and knowledge." And the Vein Week is the perfect right example of it. Deeply thankful. Thank you so much.
Thank you so much, Wasila. Now we focus on the fact that this is Vein Week Italy. So we usually in Italy have a 15 minutes delay in our academic activities, and indeed we are perfectly on time to get started. We tried in this format with Willy and Oscar to put on the table some hot topics of unmet needs and allow ourselves to use the top Italian experts we are honored to have here today with us in an interaction with top international experts. So here there is the topics brought by Willy, and then we will have Willy hopefully live joining us. I see he's already here actually for the answers.
Hello, everyone. It's my great honor and pleasure to be presenting this topic at the Vein Week program. The topic I was given is the unmet needs in superficial venous devices. I do not have any disclosure related to this talk, but I will be talking about non-FDA approved devices. So first, I want to go over some of the key points in terms of the non-invasive and invasive management strategies that we currently have available and the possibility in the future. First, when we talked about non-invasive devices, we typically think of obviously medication and also compression. Now, in terms of compression therapy, we have many modalities, and all of them that are currently available in the market, but more and more of these products will be available as commercial products. This one here in the middle that you do see. But one major focus of the non-invasive management is actually interface pressure measurement. And as you can see from the past, we have PicoPress, Kikuhaimi. Juzo came out with a new product within the last 3 years. Certainly that the technology is moving towards more wireless control unit. Now, as far as invasive therapy, first, when we talk about thermal, typically we think about laser and radio frequency. Obviously, we're not going to list the number of laser companies, which we're all familiar with. In terms of our RF companies, we have Medtronic, Olympus with the Celon catheter, F-Care, and Vein Close. Other type of heating or thermal modality, including steam, and also a microwave device, the ecosystem, which is made in China. Now, as far as non-thermal, non-tumescent therapy, we have therapy that's mostly related to some foam delivery system, whether it be the flubograph or the clear vein system, which again requires sclerosing along with some form of endothelial damage, rather by fast rotation of the needle tip versus a uh, versus some form of a scratch uh, mechanism. Others would be the foam therapy, and then last but not least would be our commercially available canister-based foam manufacturing, and that would be the Verithena device. Other type of non-thermal, non-tumescent therapy mostly involved the cyanoacrylate adhesive ablation device. Currently, we have 3 on the market: the VenaSeal device made by Medtronic, the VenaBlock, and then the last but not least, very close. Other type of non-tumescent, non-thermal device, including the ScleroSafe device, which has a syringe technology whereby that the vein gets drained at the same time that foam is actually be infused. Other devices such as the ScleroSafe with the V-block, you have a sort of a stent that's actually placed proximally at the saphenofemoral junction, and whereby that the foam is infused in a traditional manner. Others, such as a high intensity focused ultrasound or the HIFU device, which has been mostly used in Europe. Now, as far as data from these devices, this is actually one of the representative papers looking at both the cyanoacrylate as well as RF and the laser device. As you can see that over a period of 2 years, that you can see the decrease in VCSS is across the board throughout the 3 device modalities, and patients receiving those 3 management modalities all benefit with more significant improvement in the cyanoacrylate group. Other type of superficial invasive therapy includes internal compression, whereby cyanoacrylate and hyaluronic acid is actually being placed around the site of venous valve dilatation externally. So in this case, that you will use ultrasound guidance, and then the solution is actually infused outside the vein to basically compress the dilated vein segment where the valve is, to basically, hopefully, to resume normal valvular function. For the saphenous technique, there has been some published report, particularly from Sergio Giannassini's group, looking at using thermal device in doing the Chiva and the OSFOL procedures. So where are we? Do we need another modality? And I think that Alan Davis has really put this in question into play. And I believe that what he has said at the bottom is actually the most important, is that the best treatment is tailored to the patient. And any type of device that we're going to come up with needs to have better and longer term follow-up. So hence my conclusion, there always will be a need for innovation, whether it be superficial or deep. But more importantly, education, both for the patients and the practitioners, as well as cost effectiveness of treatments and regional differences in terms of affordability are very important in terms of the future advancement of both superficial and deep venous work. But most importantly, using the most cost-effective method to treat the right patient at the right time is the key to the advancement of the field. And with that, I want to thank you for your attention.
And we deeply thank Professor Chi. I see Willie is here. Willie, can you hear us? I know that you are in clinical hours, so thank you so much for taking the time. Indeed, as I was saying, Vein Week is during the week, so it is quite difficult for everybody, of course, to be available, but I like to deeply thank you for finding a minute to join us. And this is the moment in which we are the most delighted ones, because we are reaching out to Italian top experts to interact with international ones. And it's my true pleasure to introduce Professor Edoardo Cervi from the University of Brescia. Of course, he's engaged too. So here is his question for you, William.
Hello, everyone, and thank you very much for this kind invitation. For my discussion, I want to start for the question he proposed, Professor Chi. Do you need another modality for truncal vein ablation? In response to the need for less invasive treatment, many techniques have been developed. A 2014 Cochrane review concluded that endovenous laser ablation, radiofrequency ablation, and foam sclerotherapy are as effective as surgery for great saphenous varices. For all three therapies, rates of minor and major complication, including persistent brightness or tenderness, skin alteration, skin staining, are relatively low. Most recently, new non-terminal, non-tumescence treatment have been developed to overcome the shortcoming association with terminal ablation. But the point is, it's possible to standardize only one method. I think that is impossible because we have many variability of superficial venous anatomies and hemodynamic. And the surgeon must know all the technique for the treatment of the patients. Thank you very much. Have a good job. Bye.
Willie, can you make your comment?
Yeah, I can. Thank you. I'm going to be short. So from my perspective, I don't think it's a matter of I don't think we need anything, but do we want? Now, as scientists, I'm pretty sure that any field, as we advance forward, we're going to have new innovations. But I think more importantly, what we need to do is to assess, again, the cost effectiveness based on region, based on personal preference. And I totally agree that that any one of us, none of us is versatile in all the procedures. So I think the focus is to have a few of the tools that we excel at and treat our patients based on what we do the best. And I hope that answers the question.
Thank you so much. And I have to say today, Oscar and I are feeling blessed because we cannot keep Willie with us for all the webinar. He has to go back to his patients. So we'll have the pleasure of having two real phlebology queens making the honors of the host of the event. So Lorena, would you like to introduce the next expert from Italy?
Okay. In English, okay. I'm going to present Dr. Domenico Baccelleri. Great.
No, I understand it's a little bit difficult from you because you are in remote from Costa Rica. So it is, again, our dear friend Paolo Valle from Italian Association of Phlebology, and he's actually the proponent of the Phlebart project. That is a very interesting Vein Week project as well. So Paolo, you're live with us. Would you like to make the question to Willie in Italian if you want?
Congratulations, Willie, for your interesting relationship. In your opinion, what is the in-base device that will improve the cost effective in the future? Thanks.
Okay. Can I go ahead and answer the question?
Yes, please, Willie.
Yeah, well, I think if you're talking about the currently available methods, and which one's most cost effective, I have to say it's most likely foam therapy, just because obviously it is not the most effective, but it is the most cost effective. It's cheap. It does not require extended amount of special training. So I think for those reasons, it could be used by many doctors throughout the world to do it, because it's a simple enough procedure to do where a patient.
You have some poor connection, Willie? Okay.
Okay, can you hear me?
Yes, we can.
Okay. Do you need me to repeat the answer, or you got the answer?
If you want just to give a little sum up.
Okay, sorry about that. So what I was saying to Dr. Valley is that I believe that foam therapy is the most cost-effective procedure. It is not the most effective procedure, but based on what we know about foam therapy, it does not require extended training. It is simple to use, and it's actually available throughout the world. And because of those reasons, I think that just from the dollars perspective, with quality of life years gained, I believe foam therapy will probably be you get most bang for the buck.
I saw Professor Tessari nodding, so I think it is a Tessari approved.
Whatever makes Lorenzo happy. That's
sure.
Great.
So just moving fast because your patients are waiting. Again, the other queen we have with us today is our Wasila Taha. So Wasila, would you like to introduce the next top Italian expert?
Yes, Sergio, I'm truly honored to introduce Professor Francesco Zini, a leading figure and the master of SPAL technique. And we were honored having him during one of our Saturday night vein talks last September in LATAF 1 project. Professor Zini, the podium is yours now.
Francesco, you can make your comment.
Sì, buonasera a tutti. Sono onorato di partecipare a questo colloquio internazionale.
Good afternoon or good evening. I'm honored to participate in this international meeting. I have seen with satisfaction Willie's presentation, and that he says that we have different possibilities to treat superficial disease, venous superficial disease. But I believe that we all should try each one of the methodologies in order to understand which are the differences among them. Personally, I have tried all of them except ultrasound and vapor or steam. And I must say that what has affected me the most in the presentation before was the last sentence when Willie was saying that it's important to adapt each one of these methodologies, each one of them, to the patient to be treated. Different patients must be treated with different methodologies. That's absolutely correct. And most probably, if we try all of the different methodologies, for sure we will find the one most applicable to our patient. Since 2004, when I worked with laser, then I worked with radio frequency, and then for 1 year I worked with blues, and then in 2014 I started using SPAR. That is, together, sclerotherapy and laser together. Precisely along these lines, I should say that I have been able to choose the method that is most adaptable to the kind of problems and patients. And I think laser is the one that is more adaptable or interchangeable in order to better adapt to the different types of patients. And something else, changing between sclero and laser, we will find the right treatment in between them for all superficial diseases.
I guess I'm very fluent in Italian now, Sergio. Well, good to see Francesco again. Last time we were together was in Dominican Republic. But based on what I know about your question, obviously you're the world expert on the sandwich technique.
with the foam and laser. From my perspective, I believe that laser, obviously, it's a much more versatile thermal device to use, because the energy level could be changed as versus other type of thermal devices, which obviously the energy level cannot be changed. It's a set. So I hope that answers your question shortly. I have only probably a couple more minutes because I have a patient that waited for about half an hour already. So
super fast.
Do you want to go ahead?
Yeah, super fast question from Professor Mansilla.
Thank you, Sergio, for this kind invitation, and congratulations for this initiative of the Vein Week. Thank you, Willie, for your great talk, your complete overview on different devices to use on chronic venous disease. You raised several important points. Let me address one that is related with long-term results and impact on quality of life of these different techniques, as you mentioned, and reading the latest guidelines published by the European Venous Forum last year at the International Urology Journal, you cannot find differences between modern open surgery, radiofrequency, laser, or ultrasound-guided foam sclerotherapy. So my question is, what are we missing to define an individual algorithm in order to choose the best strategy using these different techniques for our daily practice? And for this question, it is or not important, in your opinion, the clinical, anatomical, hemodynamic patterns, the advantage and disadvantage, and also the costs of different techniques, and last but not least, the skills of the practitioner. Thank you.
We thank Professor Mansilla. Willie?
So thank you, Armando, for the great question. So I will answer in two different ways. I think that first of which, I believe quality of life years gained is something that has been published, but we do not put focus on as a phlebotomy community. And I do believe that that's going to come more and more into play, especially with declining economic parity throughout the world. And again, that has to do with cost effectiveness. The second question, I will put it in a simple term. What is the best therapy? I think that the best therapy depends on the physician. So whatever best therapy, it's up to the practitioner, and use that tool at the right time to the right patient with the right cost.
Willie, thank you so much. Please run to your patients. It has been really appreciated you join us live, and we'll see you soon during Vein Week. With this, we deeply thank also Professor Mansilla, who was our international expert for this round. There is, as always, a question from the audience. In this case, it's from Jose Salas. I will take it on behalf of Willie. The question is in Spanish, and it's asking if the sclerosis by foam, by means of dedicated catheters for the saphenous vein with tumescent anesthesia can be a proper treatment. Now, this is an Italian pride because Attilio Cavezzi is one of the main proponents of this technique. I will briefly say that, of course, it could be, and it has been considered a potential solution, in my opinion, but of course, as always, we need to produce evidence-based data. And I'd like to quote an editorial of a couple of years ago that was talking about endovenous thermal tumescent results, talking about a perfect storm of unuseful data, meaning that if we don't put this data in an homogeneous way with also hemodynamic parameters, as Professor Mansilla was pointing out, we get the risk of comparing apples and oranges. But I will leave for the honorary chairs further discussion on this, and we move forward to catch up with the webinar. At this point, I will put myself in trouble talking about the peri-procedural management, and we will go back to the brainstorming we had with national and international colleagues following the Winter 2019 meetings on this topic, for which you can find the results of this discussion in this publication of Phlebology Journal. If you're talking about peri-procedural, it means, in my opinion, that we start from the pre-procedural phase, and we could discuss about putting or not compression on. Now, it's interesting to me the fact that if we are in US, we need to prescribe some weeks of compression before obtaining a reimbursement from the insurance. While if we fly to the other side of the Atlantic, we have an indication in not using graduated compression stocking unless the procedure is unavoidable. If we stay in Europe, though, we have an indication with a grade 1B of using graduated compression stockings in chronic venous disease patients at risk of developing swelling, which indeed I think is our population waiting for the procedure. Then we could brainstorm about prescribing or not venous active drugs. And this is a good opportunity, I think, to specify the need of always giving a name and a surname to the venous active drug we are talking about, because if not, we get the risk of diluting the evidence in a whole group of drugs that cannot be, of course, assessed in group, but should be assessed individually, both for the ulcer treatment and for the chronic venous disease treatment. If not, we see also there is quite an heterogeneity in the guidelines around the world. Moreover, it's quite a shame we cannot really discuss in depth on the topic with colleagues from US, for example, and UK, because up to my knowledge, they don't have these drugs available as we have, for example, in Italy. If we look at the most recent reviews on the topic, we see that MPFF has been validated through the 6 clinical classes, and that there is an interesting action, particularly in the anti-inflammatory and anti-thrombotic action of surodexide, that could be of interest in this COVID time, as it has been also pointed out by this recent review of Big Daily. But then we go to the procedure room, and we see that if we have to treat a great saphenous vein, there is homogeneity in terms of recommendations in the different guidelines around the world, with an indication 1A or 1B favoring endovenous thermal procedure. It's another topic if we move to the small saphenous vein, as we can see from this bumpy line of different recommendations. And if we really want to dive into the discussion also, we don't have that much of data at the long follow-up. But I think we should always look at the results we are looking at, because it's not just anatomical recurrence rate, it's also about, of course, patients' reported outcome, it's about quality of life, it's about the cost. Moreover, it's about the velocity with which these recommendations get outdated. If you look, for example, like the example of 2020 guidelines from the European College of Phlebology, not taking into consideration the glue at 5 years, that indeed was already outdated in the same year, because the VCLOS trial came out with a 5 years result showing a potential competitiveness of Benecil versus radiofrequency. But then in the operating room, we could decide of staging or not the procedure. Now, there is a tendency now in the guidelines of indicating contemporaneous treatment of the tributaries, and we could discuss about the results also of a recent analysis on this topic that is showing quite contradictory results. But we also could think differently in the operating room, and rather than treating just the trunk and then see what happens to the tributaries, treat first the tributaries and then see what happens to the saphenous trunk in a saphenous sparing approach that keeps on showing from the times of Franceschi and all the investigations done along the way, competitiveness in terms of anatomical recurrence rate. Of course, the big topic, particularly in COVID time, is thromboprophylaxis. And in terms of thromboprophylaxis for venous procedure, maybe we have still some work to do before coming to a homogeneous consensus. There are some interesting surveys showing from Ireland and Greece, for example, the heterogeneity in the practice. And we should also brainstorm more about how long we want to go with these thromboprophylaxis. Maybe just one shot of heparin is not enough if we consider that there are papers showing that there is a risk that is up to 10 times higher of thrombosis up to 6 weeks after the procedure in a day surgery procedure. For this reason, once again, we could not be more blessed than today in having Professor Caprini, who really taught a wonderful sentence to us: never kill a friend, never treat a stranger. So the importance of knowing our patients' risk factors, like if they were our close friends, so to avoid the risk of killing them by a thromboembolism. For this, I really suggest you to print and stick on your office wall the Caprini score, and there are also other scores, of course, available, but if you watch, for example, these scores, they are really not specifying the kind of varicose veins we are talking about. Another thing we could discuss together, particularly in this COVID time in which we have a risk up to 4.5% increase in terms of thrombosis in our not ICU patients in that publication. Moreover, we have indications that we could brainstorm on an eventual update of the Caprini score, and it's wonderful that the same Professor Caprini is now co-working with different groups internationally to use the score also in different scenarios. Going toward the conclusion, after the procedure, we could decide about compression or not. And if we look again at the document I was mentioning at the beginning, we see that there is a significant heterogeneity in the timing of compression after a procedure, ranging from 24 to 3 weeks according to the different recommendations, and also the dose from 16 up to 40 millimeter mercury. And then in conclusion, after the procedure, we could discuss about the use eventually of anti-inflammatory drugs and venous active drugs to limit the domino effect from the micro to the macro aspects of the circulation, with publications like this one showing that the disease really starts early at the C0s with a decrease in the functional capillary density, for which lab studies like this one on MPFF or sudodexide are triggering some discussion. Also like this one showing the anti-inflammatory effect of sudodexide in the hyperpigmentation after sclerotherapy. In conclusion, HEAT, I think it's interesting to notice how the most recent document on HEAT from the AVF is showing a lot of 2Cs for which maybe some further discussion is needed, or maybe it's not needed at all, because we understand that HEAT are not really a big concern, but we also know that one case is enough to have serious issues. But in terms of surveillance, and this will be my last comment, this interesting publication is showing that with more than 13,000 procedures of endovenous ablation, no death reported, for which we had a cost of more than $14,000 to detect a VT that was not even lethal, for which maybe in the future indications of strict surveillance in the post-op phase will be not needed, but this does not mean not to give a proper risk assessment of these patients. Of course, I will look forward for discussing in person all these things together in Dubai. With this, I will introduce the first question from a dear friend and a huge professional figure, highly involved in the thrombosis management, particularly during the COVID time, from the University Hospital of Padova, Giampiero Bruscia, and here is his question, for which I will have to try again to go to the Italian channel and play his video.
Caro Sergio, intanto grazie per l'invito.
Dear Sergio, thank you for your invitation. Greetings to everyone and congratulations because of your regarding your very interesting presentation with our pathologies and the interaction with COVID. We know that these pathologies are frequently associated with thromboembolisms. There have been some publications, recent publications of patients in intensive care, even when using heparins. We have found many cases of COVID with DVT, in some cases fatal cases. So I would ask you, when we talk of the COVID pathology, that we have to take into account the use of fundaparinox and other heparins in order to see to have time to see what finally the international guidelines say in this regard of COVID and venous pathologies.
And with this, I deeply thank Giampiero Bruscia. Indeed, I think the difficulty of COVID time is offering us the opportunity of remembering the importance of the thromboprophylaxis, something that sometimes we underestimate. Again, we know the venous procedures are particularly safe, but we also know we have reports that range up to 16% of DVTs after a procedure. So I think this is the case for remembering what I said before, to print the risk assessment score and stick it on our office wall to use it every single day. We have different tools we can use. I think that the really interesting thing is the report that was done in a survey from Ireland and Greece showing the heterogeneity of practice around the world, with a significant amount of subjects, of colleagues, still prescribing one single shot of low molecular with heparin to everybody. So I think one size does not fit all in this, and Professor Caprini himself taught us to really stratify the risk. With this, I will go now to Costa Rica, and I will ask Lorena to finally introduce Domenico Baccellieri, who she was eager to introduce before, and now it's really the time for Domenico. So
thank you, Doctor. I'm pleased to introduce Dr. Domenico Baccellieri, who is a great professional from San Raffaele University Hospital. Dr. Domenico.
Domenico, if you want to unmute yourself, if you want to make the question.
Yes, thank you, Sergio, and thank you, Willie and Oscar, and all the BWIN Foundation for involving me in the Vein Week. And it's a great pleasure to be here today. I think that it depends on the physician feelings to decide the technique and the management in the pre and the post-operative phase. I personally used to prescribe stockings and venoactive drugs in the pre-operative time to adapt the patient to the post-operative therapy. And regarding DVT, I think that we can design a randomized controlled trial comparing the use of low molecular weight heparin and sulodexide in this kind of patient. Regarding compression in the post-operative periods, I think that we can start with a short compression period and then establish with the patient the possibility to stop and tailor the compression regarding the problem of the patient. Thank you very much.
Thank you so much to you, Domenico. My only comment on this is that indeed it is really needed, in my opinion, to have more data on this aspect, in particular also on the length of the prescription time. That remains quite a question mark in my head, particularly after reading these surveys showing heterogeneity also in the length on the thromboprophylaxis. And now we fly on the way to Sicily, thanks to Professor Wasilata, who will introduce the next top Italian expert.
Thank you, Sergio. It's really a huge pleasure and honor to introduce Professor Edmondo Palneri, a huge professional from the beautiful other bank of the Mediterranean Sea and very near to our country, Egypt, from the unique city, Sicilia. Dr. Palneri, please. Edmondo?
Bene, adesso io parlo in italiano perché passiamo al video in italiano.
I will speak in Italian because there's a video that will be in Italian, so.
I will take Italian lessons, don't worry.
Vorrei ringraziare per il coinvolgimento, per questo piacere di collaborare.
I want to thank you for the pleasure of being of collaborating and being present in this international event. The Directive Educational Committee and Foundation, I wish to thank them both, and chiaramente and clearly my friend Sergio Giannesini. I would like to pose my question now. We know that compression is a must in our phlebology practice. The international recommendations as to duration and amount of compression shows that there's a need to work together in order to put together recommendations. What is, Sergio, your opinion and your experience regarding post-surgery compression?
English? Okay. So I'd like to deeply thank Professor Palmieri. Again, this is, let's say, empirical, because as also a AVF document Professor Luri showed us, we still have to find clear evidence on this. We usually use 3 weeks. I usually use 3 days and night, and then only day for 3 weeks' time if you're talking about surgical procedure. I like to point out that we are performing those saphenous-sparing procedure in which we are looking for more and more benefits of compression, which is not just the hematoma control, for example, that somebody might think about when they are performing endovenous thermal ablation, for example, or tumescent assisted procedure. I think the key message is that compression, as it has been also demonstrated by biochemical analysis, is far more than a physical tool. It's also a biochemical tool indeed, and it is used as an anti-inflammatory drug. For this reason, we tend to use it as long as possible after the treatment. And the compliance in this case is strictly related also to the good prescription. It has been demonstrated by the Raju group that more than 60% of cases of not compliant patients are because of a poor prescription. So I think we have a powerful tool that we have to investigate more and more for evidence-based needs, but that can for sure, particularly in the risk-benefit ratio, help our everyday practice. With this, we go toward the end of this session with Professor Raffetto, that is, of course, a huge figure from Harvard and is, of course, working in this moment. For this reason, we have his question.
Good afternoon. My name is Joseph Raffetto. I'm talking to you from Boston, Massachusetts, and truly a pleasure to be discussing Professor Genesini's wonderful presentation on peri-procedural management. These are very difficult topics and very comprehensive that Professor Genesini covered. So many of these procedures are performed in an office-based setting. Many of the patients are actually fairly healthy. They do ambulate well, and the procedure has very low morbidity. Based on this, I would like to ask Professor Genesini which supplemental or ancillary procedures or treatments that have a grade 1A evidence should be applied to patients undergoing superficial venous ablation procedures. And 2, because chronic venous disease is a spectrum of C0 to C6, are there certain clinical classes that we should be more concerned about peri-procedural ancillary treatments? I look forward to your responses. Thank you again, Professor Genesini, for a wonderful opportunity.
And I'm happy that I had the chance to listen to the questions before, because it's really a Harvard-style question, so really tough indeed. So when he was asking about grade 1A supplement, in reality, the only one we could mention in this case is MPFF for the control of venous system, symptoms. But this does not mean, of course, the peri-procedural control, for which we will need further evidence, for which I think the answer to that is that if you're talking about 1A, there is nothing over there in terms of peri-procedural. If you're talking about 1B for graduated compression stockings, for example, in terms of the risk of developing edema, again, it's not 1A, but it could be something to be taken into consideration after proper evidence-based data. Talking about the question he made on the C0, C6 spectrum, I will go back to the risk-benefit ratio, and I will point out that in a C6 patients, the risk of recurrences has been demonstrated to be significantly higher if you don't have proper compression, up to 9 times after the treatment, for which my main concern would be also for the social cost that the disease has on instructing these patients to have proper compression. All the rest not only requires further evidence, in my opinion, but very probably does not even require CEP classification, meaning that we need further tools, not just the CEP, to come to a conclusion on this. With this, I deeply thank everyone. I see we have no other questions currently in the question and answer box for the audience, and then we can then move toward the end with the last session dedicated in this case to lymphedema, for which it's my huge pleasure and honor to have the talk of the same Oscar dedicated indeed to lymphedema. So allow me just to get his talk, and then we will have him live for the answers to your questions.
Firstly, I'm very glad for participating with the World Health Organization and all of you in this brilliant Vein Week that has started today. I would like to brainstorm with you on some hot topic we identified up to the last big winter meeting in 2018. And looking at the guidelines from all around the world in their similarities and controversies, I have no conflict of interest to declare. But I declare that it has been extremely interesting to co-work with so many friends and colleagues from all around the world, who I really thank for their engagement in the different chapters of this document. Chapter 10 is dedicated indeed to lymphedema. It was a pleasure to co-work also with young colleagues and top experts, including also guidelines from Latin America. These are the guidelines we looked at in this chapter, pointing out the importance of using the same staging system. As you can notice, ISL was using a 4-stage system, and in LATAM consensus, they used the 5 different stage system. So it's important we use the same language in order to communicate the best among the continents. Another thing we notice that the CDP, of course, is extremely important in everyday practice, but as pointed out by BM Shea in 2018, it's really important to specify what we mean by CDP in terms of standardization of the technique, because if not, it is really difficult to come to a valid conclusion on its benefit. We should bring together the different schools in the world to obtain valid and validated conclusions. In terms of compression, we know it is a pillar in lymphedema management that it is also important to stress out the interface pressure whenever we are using compression in this patient, because as you can see, there is a wide variability in the indication, and also there is a wide variability in the real pressure that is inserted. So reporting the interface pressure is always extremely important. Regarding compression grafts, it has been demonstrated in the past years its effectiveness in this patient. It is a valid attempt to the other forms of compression. We could discuss more of this aspect, particularly in lookup time, where it's difficult to see patients in the clinic. A special mention of flat tissue stockings for this pathology. IPC has been associated with different level of recommendation. The volume reduction percentages have always been achieved with the help of different devices and protocols. And it is only the Latin American guidelines that specify the number of cycles per day that would allow the technique to be standardized. Mesotherapy is used in some countries, but the potential risk it involves for being a transcutaneous therapy must be considered. We need more evidence on these issues. Pharmacotherapy, which is widely used, requires more evidence according to the 2018 guidelines and recommendations. Surgery must be performed after 6 months of CDP according to the UIP, and all the recommendations agree that it requires to be accompanied by other therapies. Not being able to obtain good results by itself. Concerning compression, we must discuss the benefits of low compression to reduce edema, especially in the initial stages of the disease. We also should compare bandages versus flat tissues compression stockings and the different compression wraps, especially during these pandemics that forces patients to self-care. It is very important to assess the interface pressure in B and B1 in order to clarify the necessary pressure. It is essential to evaluate the compliance of this patient and the real contraindication of compression in patients with arterial disease. Treatment with APC in patients with trauma is rarely used by the specialist, since only 19% receive it as risk prophylaxis for trauma. Protocols should be standardized. Finally, we need to obtain data that can be compared. CDP should be defined. The SOCs are globally recommended, but with different pressure levels depending on the manufacturer and the regions. IPC is recognized in different protocols, but not as the only treatment. Mesotherapy and surgery are highly controversial, and we can all agree that neither of those options can be used as the only treatment. Assistable compression wraps are suggested as a treatment, especially in times of pandemic that forces self-sufficiency. Other aspects, such as those mentioned on the screen, must be considered. All this and much more information await you at Buenos Aires 2021 from September in the last week. Thank you.
We thank Oscar, of course, and it's my huge pleasure to introduce Corrado Campisi, who is an absolute leading figure nationally and internationally in the lymphatic field, and also to congratulate him because on March 6th he developed a great lymphedema day. So I hope that lymphedema and venous disease will go on working together in public awareness and in science. Corrado, the mic is yours.
Okay, thank you, Sergio, for this invitation, and this event all this week is gorgeous. And my question to Oscar is related to the last slide of his presentation, and in particular the need of standardized centers. Recently, we have performed during the World Lymphedema Day a strong collaboration between the Lymphedema Education Research Network, that is an American network that widespread all around the world, and it is extremely useful to have standardized centers that propose a good level of care. Now there are more centers also around the world by Lymphedema Education Research Network, and I think this is a good way to offer the patients and also the colleagues the best level of treatment. I don't know what Oscar thinks about this, but I think it is a very good option, is a peer-reviewed center that needs to have certain levels of evidence-based medicine level of care. So this is my question. Thank you.
Sí, voy a contestar en español, Sergio, si me permites, para tener más amplitud.
I will answer in Spanish so that I have a broader vocabulary. Thank you.
What
I can say, as you know, in the university or college environment, it's very easy to simplify information, but in the lymphatic realm, we have a lot of variability in techniques, in the types of compression, variability in several categories of treatment, even the skills of the physicians. It's very difficult many a time to standardize some basic concepts. And I think it's an excellent, a brilliant idea what you're saying, because this will enable at university level to have education. A lot of people have different schools, different, I mean, they become fans of a specific school, so to speak, and then they have the skills for something, but it's not a real evidence-based learning, as you're saying. So I completely agree with what you're saying. And I think that at some point we will have to join forces to be able to benchmark, to compare different procedures and in an isolated way and not jointly as it's being done currently. Thank you.
Thank you, Oscar. And now we fly all the way to Italy, Marche region. Thanks to Lorena Grillo, who will introduce us the next top experts from Italy.
It is a great pleasure for me to introduce Dr. Attilio Cavezzi, of which we here in LATAM are huge fans, since he's such a great expert in many of phlebology and nymphology topics. And he is also past UIP Vice President. So Dr. Attilio Cavezzi, is an honor to introduce you.
Here the question for Oscar.
Congratulations, Oscar, for your lecture concerning lymphedema. You highlighted the need of more evidence, somehow the suboptimal evidence that we have concerning lymphedema diagnosis and especially therapeutic management. So my first question would be, what do you think about manual lymphatic drainage, which you covered just a little bit in your presentation? And also, I would stress the point that the adjustable compression wraps could represent an interesting option because of the self-management of lymphedema is becoming more and more important in our healthcare system because of lack of funding and because of COVID or whatsoever. So these are my two questions or comments. Thank you again, and I enjoyed your presentation.
Thank you, Attilio. And now, Oscar.
Bueno, gracias, Attilio.
Thank you, Attilio. It is an honor for me to receive your comments, so brilliant panelists. This is a question that I really like because in our center in the University of Buenos Aires, we've created self-management by patients, patient self-management. Our big problem in this specialty is that this is a chronic disease. It's treatable, but it's not curable. So we need constant care of these patients. So many times we get patients at congresses and we see the efficacy of treatment, and afterwards that patient comes to our office and he has a recurrence. And this has to do with the fact that the prepaid insurance or HMO is not providing care on a daily basis. And it's very hard to sustain the treatment throughout time. So I think that self-management for these patients, and this is what we are doing, it's not just the bandaging, but also the drainage to be done by the patient. It's a way of self-managing the disease, which provides better results in the long run. As for compression, the queen or the king of our treatment, even more than drainage. We all know that lymphatic drainage in advanced patients, especially with high protein content lymphedemas, the only way to evacuate particles is through drainage or manual lymphatic drainage. But compression must be done on a systematic basis. And I believe that compression, and of course, we're talking about high compression. This is very important. As for different devices, features for the adjustable wraps, well, I believe this is very relevant, especially in the pandemic setting, because it allows patients to self-care, to self-assist, because many times stockings are difficult and hard for these patients. So to conclude, I would say that these new compression techniques are very useful, although there are not many studies or evidence that can prove it so far. Thank you.
Thank you, Oscar, and thank you, Attilio. Now from the Marche region, we fly to the Lombardy region. Thanks to our Wasila Tau, we'll introduce the next Italian top expert. Wasila.
Thank you, Sergio. Yes, it's a huge honor to introduce Professor Domenico Corda, a huge expert in the lymphatic field. And congratulations, having published a recent Times book, which is really a just masterpiece and a must read. And it will be a huge honor if you could join us tomorrow, panelists and attendees, during the class training course of lymphedema, streamlined from Cairo at 11 GMT time. Welcome, all of you.
And I'd like indeed to take this chance to invite all of you to visit the website with the software dedicated, because you will see that indeed from Egypt, everything starts for real, because many events started today and will go on for all the Vein Week. And here is the question for Oscar.
Yes.
Dear Oscar, my congratulations for your update report on lymphedema guidelines. I have only a comment about CDP-related problems, and I agree with you that we need standardized and certified centers with recognized specialists. In CDP studies, we have a lot of bias, above all linked to the individual variability, the lymphedema variability, the techniques variability, and the specialist variability. We have to work together to solve these problems with an international and educational and homogeneous school for managing CDP. At the moment, CDP is the therapy for the life for these patients, with and without surgery, and with and without drugs. Thank you for your attention.
Oscar.
Sí, gracias, Domenico. Bueno,
Thank you, Domenico. This is what we were just saying, huge variability. I wouldn't include the specialist because it's very difficult to know who should get accreditation and who shouldn't. We know that in our area, we have a lot of interests at stake. It's difficult to judge this issue, but it is true to have an evidence-based medicine. We have the need to have multi-centric randomized studies, and to join the different schools would enable us to unify treatments. So I agree with the rest of your comment. So I have nothing more to add. And I thank you very much for your questions and your comments. Thank you.
And Oscar, I think it will be your honor to introduce the huge figure from Argentina who will make the last question. Oscar?
Yes. Yes. Voy a decirlo como siempre en inglés. Last but not least, I will introduce a friend from my hometown, Dr. Miguel Amere, elect president of International Society of Lymphology. Miguel.
Yes, and we are deeply thankful for the International Society of Lymphology presence indeed in these cooperations with the Venous Ward. Here is the question for you.
Thank you, Sergio, for your kind invitation, and congratulations for Professor Bottini for this interesting presentation. And my comment is regarding the differences of all guidelines and the possibility and needed to find more evidence, for example, in pharmacotherapy or level of compression. And finally, I fully believe that the surgery, it's not only when conservative management has not been satisfactory. Today, we must to restore the lymphatic system as early we can, and highlight the key role of the preventive surgery. Thank you very much.
Thank you, Miguel. Oscar?
Sí, gracias, Miguel. Sí,
Thank you, Miguel. This is an issue that many times we've talked about together with him, Dr. Papini, also from Argentina. Early procedures assure lymphatic canals to be open for better results. But the issue is to have interesting numbers, to have good samples, to really know whether this is evident or not. We all know that all of these patients will continue with a treatment, whether compression or a drainage, or both. Therefore, it is very difficult to know whether surgery by itself could be a resolution for edema in the future. At this point in time, I believe that medical treatment is beyond the other treatments, but this is a debate, an ongoing debate, of course.
Perfect. Thank you so much, Oscar. Now we have the last 15 minutes, indeed, where we are going to wrap up this webinar, thanks to 4 huge pillars from Italy and 3 huge pillars from US. And it's my huge honor and pleasure to introduce Massimo Danese, who is a leading figure and key opinion leaders here in Italy. Massimo, I know you are with us and you like to speak live. Massimo?
Bene, un saluto a tutti, un ringraziamento particolare a Sergio Giannini.
Greetings to everyone. Thank you for the invitation to this exceptional international event. Great quality. Greetings from Italy. And I take the occasion to greet Guarnacci, Pagan, che sono colleghi italiani. No, we have worked together for the last few years in the lymphology field. So I would like to thank Professor Buttini, Willy Chi, and all of the other colleagues that I see on the screen. I must comment on everything that has been said. Everything has been excellent from every point of view. In particular, what I do every day, as Professor Bini has said, that my experience was born in the surgery of the saphenous, the internal saphenous vein. But also, I would like to point out how Professor Chi clearly illustrated the problem of creating something that is custom made for each patient. That is, the procedure has to respect what the patient needs, and also our own training and the possibility to have many invasive thermal, non-thermal treatments. That's an option that we have at hand today. And therefore, I must say that everything that we know of, everything that we can do has to be done in a custom-made fashion with the patient, considering the limitations of endoluminal treatments, for example, with anatomical anomalies, post-phlebitic syndromes, or thrombo-connected pathologies, and also the peculiarities of, for example, the saphenous veins, some more tortuous than others, and let alone something that we have not talked about, which is recurrences, the problem that we have from the quality of life point of view, and how to keep the patient far from that possibility. Obviously, technology keeps moving forward. Professor Chi mentioned hybrids, methodologies, foam, etc., which are part of our future. Also, in my current experience, with them with lower peak temperatures, for example, and more uniform transmission of energy on the venous wall in order to be able to work without tumescent anesthesia. Thank you very much, and greetings to all.
Thank you to you, Massimo. And now it's my huge pleasure to introduce Dr. Demetrio Guarnaccia, a dear friend to many of us, a huge expert from Italy as well. Mimmo.
Ciao Sergio, non so se mi sentite, spero di sì.
Hello, Sergio. I don't know if you can hear me. My thanks for a very interesting meeting, in particular the high-level international guests. And I'm sure this event is having major success. It is clear that superficial venous pathology, for that we have, as has been wonderfully said by the different presentators, we have a wide range of treatment options. I say, however, that there is, or what has been said too, that there's not just one single treatment to solve all pathologies. A good phlebologist, somebody who a phlebologist, obviously being a national level or international level, well-known or not well-known, they must have, phlebologists must have the knowledge enough to be able to understand the complete problem. It's not, we should not talk of a saphenous pathology, but the possibility of cavernomas associated to other situations of patients that were treated years ago, or patients who have not observed their treatment correctly or have not followed the recommendations. So the pathology gets complicated because of all these things. It's a chronic pathology, and the evolution of the same pathology differs in different patients and in different times. And so we need different treatments to cope with all of those possibilities, because we need to solve the problems of our patients. For example, I'm thinking of cavernomas. I'm working now with a hybrid treatment on the proximal part of a cavernoma with sclerotherapy and foam. The lymphatic pathology in is our field, and it does not depend on the professional treating the pathology. The lymphatic pathology is double, the pathology itself and the patient with the pathology. The patient many times doesn't have the possibility to follow what he's being told. And as Oscar Bottini was saying, self-management of the patient allows better results in the long term. If we think of a lymphatic patient that may come to our center for very brief periods of time, for sure that pathology will come back and even will have worsened. So the self-management of the patient or the family of the patient may be or must be actually the best way to go when treating our pathology. My greetings to all of you. And I wrap up my presentation with this. I have now moved into Italian to read this message from Professor Pagano. I think it's important and necessary to carry out initiatives like the one we're at today, because they show there is so much room for improvement and to inform on both our subjects, both our topics at a national and international level. Consequently, we require initiatives like this one to bring together the best experts nationally and internationally for the sake of our patients.
And with this, I switch in English for a big finale from Italy, because indeed we have the honor and pleasure of Marco Pagani, another big expert from Italy. And in reality, he has also been author of interesting publications of revisions on the topic of superficial endovenous devices. So he's the perfect finale from Italy. Marco?
Can you hear me?
Yes.
Yes. Hi to everybody. It's an honor for me to be able to give my little contribution to this important meeting. And that is why I thank everyone, and in particular Sergio Gianesini, for the esteem and friendship that bind us. We have listened with pleasure to some of the leading experts who have addressed very well what are still today the main controversial points that we have to deal with when we talk about phlebolimphology. We have seen the numerous technical possibilities for the ablative treatment of the varices of the lower limbs. All are proposed as the ideal treatment. All have excellent results, but in reality, we are still looking for an even more powerful technique that is less and less invasive. My personal first take-home message: perhaps we should understand better why, for which patients, and when do a sphenic ablation, rather how to do it. How not to stress the importance of Sergio's report that perfectly centered in still incredibly obscure points of the approach to this disease. Should we recommend elastocompression before proposing an invasive treatment? How long are drugs useful? Even today, we have seen that there are different guidelines. My second take-home message: the invasive ablative treatment, whatever it is, cannot be considered the first choice, and who treats this pathology must well know the principles of pharmacology and elastocompression. Should we treat the sphenic tributaries at the same time as the ablation of the sphenic axis? Even today in Italy, I'm sorry. Even today in Italy, some groups perform contemporary treatment, others not. But I think the problem is always the same. We have to ask why to perform contemporary treatment and in which patent, instead of how. Concerning routine prophylaxis, even today in Italy, some groups practice routine prophylaxis, others never use. Still others use it for selected cases, some for a day, others for 7 days, others for 15 days, and so on. So congratulations to Professor Caprini for this score, for the attempt to rationalize this aspect, still dominated by total confusion. Similar consideration for the confusion that reigns in the post-procedural prescription of elastocompression. Yes, no, as far as how. Lymphology is in continuous evolution. New concepts such as the complex decongestive physiotherapy, the controversies of pharmacotherapy, the role of surgery, the overbearing entrance of a pandemic that created new questions. My last take-home message: the road is still long, and the more we study, the more we realize that we do not know. As for the COVID, take care of yourselves. Thank you for your attention.
Thank you so much, Marco, also for being in the really first line in Lombardy with the COVID issue. And thanks to all the Italians who took part in this initiative, we are more than blessed in having 3 giants for the Grand Finale. I see we have Professor Caprini ready, so I will take the opportunity to play his recorded live, so maybe we'll be even luckier in having extra comments at the end.
Thank you very much. It's a great honor for me to be able to be a part of this wonderful.
Okay, I was trying to have a double benefit, having extra comments over the video, but it's absolutely perfect. So thank you so much. No needs of introduction for Professor Caprini, of course.
Yeah, so first of all, it's a great honor and a pleasure to be a part of this great international initiative. It's an unbelievable collection of experts from around the world and networking, sharing ideas, working together on unmet need and understanding others' needs. And the last speaker exemplifies what a lot of speakers have said. Most all of us are interested in the same things, want to do the same things, realize the same unmet needs are there. And I'd just like to go over a few of those things that I've seen that I think are important from all of these wonderful presentations, including all of the discussants and the questions that were asked as a result of the discussions. And first of all, the most important thing, and I know everyone in the audience is going to be shocked, it's risk assessment. Most of these procedures are very low risk procedures. Most of them you don't need to do anything. You should never use the word routine as far as prophylaxis is concerned, because you can't just give everybody the same dose. Everyone doesn't fit in the same shoe. There's a few bad apples in the barrel that have to be picked out. And I would suggest to all of you that risk assessment is the best way to pick out these patients. Now, once you determine that you need to give a prophylaxis, giving 1 shot of prophylaxis is to be condemned. It doesn't do anything. It can initiate allergic reactions, bleeding reactions. It will do nothing to prevent venous thrombosis. Giant study in the United States, 30,000 patients. It was worthless. A VA study. Everybody needs to go back. Everybody that uses a single shot needs to go back and look at the Alton study in the VA patients in 2012, where they randomized people depending on whether or not they got their preoperative shot or not. Did not help for venous thrombosis. Okay. That having been said, the next thing is that, first of all, Sergio mentioned some very important unmet needs regarding MPFF and the other venotonics, and also sulodexide. Sulodexide has been like an orphan child. It has many, many good uses for prophylaxis, and we need to do more work and investigations on sulodexide. Now, compression. There's all kinds of compression. And I think it's very important to use compression properly and to tailor it to the patients. When I was doing these procedures and we were doing surgery on everybody, we put on stockings ahead of time to make sure that the patients achieve some symptomatic benefit. Because if you put the stockings on and nothing happened, then maybe they had another disorder that was causing their discomfort. And afterwards, you didn't want to have to go up and tell them, well, I've done a beautiful job with your veins, but you're still having all this pain and these symptoms that you had before. That's number 1. Number 2 is post-procedure. I like, Sergio, your suggested protocol of compression, but it also has to be tailored. Nobody talks about this. 20% of those people that you do are going to have chronic swelling. So we're just going to use them for 3 days. We're going to use them for 48 hours. There's no randomized controlled trial. Baloney. There's clinical experience and judgment. And those people, after a period of time, and I would suggest you use Sergio's protocol. At the end of that protocol, take a look at their legs. Do they have edema? Do they have recurrent symptoms when they take the stockings off? Very, very important. Now let's talk about the other thing with compression, and that is the dose. And that goes for adjustable wraps, for bandages, and for stockings. We must know what the pressure interface is under those. We have a dose for anticoagulants. Why have we avoided for so long a dose for stockings, a dose for compression? And now we have some good tools. We have several good tools, and another new one coming out to look at the dose of compression. So that's very important. Please, everyone needs to learn about adjustable wraps. Adjustable wraps are my secret weapon. I've used them for years in my practice. Many patients who can't don or doff stockings don't work. They have swelling. And the beautiful thing is, especially during COVID, they're self-adjustable. And you put them on in the morning, and as the swelling goes down, of course, they'll get loose and start to fall down. So you don't come back and tell the doctor they don't work. You tighten them. Very important. Now, the next thing is that, and Alan Davies said this, and I think it's very important, you have to understand regional differences. And you have to understand, for example, Willie Chi mentioned very, very importantly, the most cost-effective method is foam. And maybe because of regional differences and so on and so forth, foam will be your first choice. Otherwise, in certain other patients, depending on what the story is, you may need to pick a different modality. So that's really important. And the big 10-ton elephant in the room are the long-term results. I can show you, I know there's studies out there that I remember looking at this years ago when I thought I did the greatest surgical job in the world on veins, that it was said that 100% recurrence rate occurs if the patients live 44 years. So this is a chronic disease. It tends to recur. And so we must make sure that we keep track of long-term results and evaluate them for therapy. And then finally, dedicated centers for lymphedema. And I'd like to say a special hello to Professor Campisi, who was so nice to me when I visited Italy. I hope someday to come back and see all my beautiful Italian friends in that beautiful country. And so then finally, I'd like to conclude by congratulating Sergio again and all you wonderful colleagues from all over the world that have helped to bring the world together. And I think there's a biblical thing with COVID. It's designed to bring us all closer together. And it's really been achieved in this particular initiative. And then again, it's a great honor to be a part of this. Thank you very much, Sergio.
Thank you so much to you, Joan. It's never one soldier, it's all the team behind this that I'd like to deeply thank, from the international to the national level. And I'm particularly happy of having you as a Caprini, as an Italian surname, today in Italy virtually with us. And talking about close friends and also family, I like to mention Professor Bibi Lee, the other giant of this project and representation in particular of the lymphatic field. I see Professor Bibi is with us. I'm talking about family for two reasons, because he's really family to me, and also because he wrote a wonderful paper about veins and lymphatics, a family affair. So Bibi, would you like me to play the video in this moment? And then we have you live, right? Okay. So give me just a second. And
good morning, ladies and gentlemen. I thank the organizing committee once again, giving this unique opportunity to me to participate, to learn more about ever-increasing appreciation on venous and lymphatic circulation as one inseparable dual outflow system. Indeed, a failure of one system, either venous or lymphatic, would give an additional burdening to the other system to precipitate a total failure of both systems altogether, resulting in a new combined condition of chronic venous insufficiency and chronic lymphatic insufficiency, so-called phlebolymphedema. Hence, proper recognition of this overlooked critical interrelationship between these two mutually interdependent systems has been overdue, and I'm so happy to see many colleagues share same view on this belatedly recognized negligence to be compensated as a whole through this conference. After all, the venous system and the lymphatic system are one happy family we will have to appreciate together. So I would like to extend my appreciation and also congratulations to each speaker as well, who generously shared their pearls through this unique virtual conference. Thank you.
We deeply thank Professor Bibi. Since we have the honor of having you here, would you like to say a final word, Professor Bibi? Okay, so we have the grand finale now. We fly all the way to Stanford University, another huge figure, really dear to the WIN Foundation, really dear to all of us, really guiding light in the lymphatic world. Professor Roxon, final comment.
Good afternoon, ladies and gentlemen. I want to thank the conference organizers for asking me to serve as an honorary chair of this very important scientific program on unmet ongoing needs in daily practice. It was a wonderful opportunity to hear these truly excellent remarks. I want to thank the three main speakers, Dr. Bettini, Dr. Giannassini, and Dr. Chi, for their very insightful comments on various aspects of the care of edematous patients. Of course, I come from the perspective of lymphedema, but we must recognize that, in fact, treating edema is a complex problem, and whether the problem originates in lymphatics or veins or some combination of the two, or perhaps even in a systemic condition that predisposes to edema, we must be very mindful of the complexity of the problem. And I think that was very nicely underscored by the comments of the speakers during today's sessions. I would like to briefly share my screen just to show a couple of slides related to today's topic. I really just want to underscore, and I believe that this came about in discussion, particularly in Professor Giannassini's talks, about the complexity of the microcirculation and the fact that this is truly where the problem originates. I think we all need to be increasingly sensitive to our growing recomprehension of the forces that drive interstitial fluid accumulation and the potential for edema. I know that Professor Giannassini and I share enthusiasm for the role of the glycocalyx in the regulation of these processes, and increasingly we're learning that this is extraordinarily important. And I think much of what we heard today would indirectly relate to these relationships, and recognizing that edema comes about through complex forces, that we do need to be sensitive to the venous lymphatic interconnection and synergism in the prevention of edema and the presence of edema in the loss of health and the presence of disease. So all of these decisions, whether they are about the instrumentation that is required to deal with the venous component, whether it is about pre, intra, and post-procedural care of these patients, or whether it is about the recognition of lymphatics and lymphedema in general, all of these are very, very important considerations. I want to conclude by underscoring the importance of lymphedema. Lymphedema, whether it occurs because there is an obstructive lesion in the lymphatics or as a byproduct of chronic venous impairment, we know that lymphedema is prevalent. It is actually on the rise. And I want to point out this recent publication in Surgical Oncology just a few months ago, indicating how important the rate of hospitalization is in the United States, and how important the role of infection in the soft tissue is within this context of hospital admission. We do recognize that mortality is very uncommon in this context, but morbidity and healthcare expenditure is, on the other hand, very common. And I think if we become increasingly intelligent about how to care for these patients, we will begin to erode the magnitude of this sort of problem. So thank you very much for these wonderful talks and for the opportunity to share my comments. It is truly a privilege to be a part of this.
We deeply thank Professor Roxon for his contribution. I see Stan is here. Oh, Stan, thank you so much for joining us. Any final comment?
Yes, just really briefly. I'm sorry, the slides that I was looking at did not get captured on the video, so I apologize.
The message went through. The message went through.
The words were correct. The image had nothing to do with it. I'm terribly sorry.
But it's absolutely no problem, because we will see you again during the Vein Week, for which we deeply thank you. So there will be, again, another opportunity also on Friday to interact with you in a multi-specialty approach. So once again, thank you for all you are teaching us.
Thank you.
Going toward the conclusion, and indeed it is the conclusion, we go back to Italy with two huge mentors of mine we deeply thank, starting from Professor Tessari. Lorenzo, would you like to make a final remark? Lorenzo, unmute yourself.
Sì, grazie di cuore per aver ascoltato questa riunione.
Thank you very much from down deep inside. Thanks to all the Italian colleagues, but in particular, I applaud Sergio's work with the foundation and with Oscar Bottini, showing how important it is to get together nationally and internationally. There's 4 very significant societies in Italy that got together for this meeting, and also the international collaboration. This webinar has shown the importance of acting on scientific evidence. We have seen experts today who show how important it is to know venous and lymphatic pathologies, not only from a physician's side, but also from the general population side, not just the international scientific world, also society, our communities, and also institutions, ministries, for example. The sports medicine in Italy has generated over this pandemic period where it has been so difficult to get together. But despite the difficulty, or maybe thanks to the pandemics, we have been able to do even more, I think. My greetings to all of you, and looking forward to seeing you face to face at some point in the future.
We deeply thank Lorenzo, of course, and it's our pleasure to conclude, since we are so focused on evidence-based, with the highest evidence-based production we have from the University of Ferrara, our full professor, Professor Zamboni, and his final remark.
Ladies and gentlemen, good morning. I thank very much Sergio for inviting me in this beautiful webinar, very interesting, great talks, great speakers. Congrats to everybody. Now we try to rapidly share my screen. For the final remarks. The key point is the transmural pressure, because in my opinion, it's the key parameter of drainage. You know, the transmural pressure, the difference between the internal venous pressure, considering either at the level of the major venous trunk or at the level of the capillary bed, and the external component of the pressure, the subcutaneous tissue, the atmospheric pressure, and of course, the Starling oncotic pressure. We know in chronic venous and lymphatic disorder, we always have an increased TMP. So the philosophy of the treatment is to decrease TMP. Each treatment showed today, or their combination, have today this key of lecture. The more intuitive treatment is leg elevation, because leg elevation decreases significantly the internal component of the venous pressure and correct TMP. Surgery and foam both act decreasing internal venous pressure and decreasing consequently TMP. For example, in a case of deep venous reflux, due to valvular incompetence, a procedure like Kistner surgery may efficiently correct the internal venous pressure, or in case of varicose veins, either sparing surgery, disconnection, or ablation may reduce the internal venous pressure. Although, as Sergio said today, I prefer the saphenous vein sparing surgery, both ablation and sparing surgery may efficiently reduce TMP. Compression acts increasing the sternal component to the contrary and consequently decreasing TMP. For example, consider the water increases the sternal component as well as the stockings of internal pressure, pneumatic compression. But what about the drugs? The drugs act on the consequence of TMP in terms of chronic inflammation. And this is a very important point. The open question is, may now do this better? My answer is yes, but this of course merit further webinars and discussion. And so I say hello to everybody with this open question.
And with this, we conclude. It would be wonderful if now we could all go, as for the old-fashioned way, for a social gathering together, as it was at the last winter meeting. Of course, the road is still quite long before that, but we stay absolutely positive, not just to the virus, of course, but to the fact that we can go on sharing science and soon also social moments. We think a fundamental sharing will be the one of fighting venous lymphatic fake news. And as you know, this will be the focus on the Dubai project, for which I deeply thank the Italian societies involved in the project, together with all the other societies around the world. Everybody can report eventually encountered venous lymphatic fake news in this website, and this will lead to the creation of a consensus document that will be presented indeed during the Expo in Dubai, where hopefully we'll finally be together again in person. Meanwhile, staying virtually, in this website, everybody can join the Vein Week project. I deeply thank all the faculty that today virtually joined us in Italy, with a particular mention to our Italian colleagues. If you want, tomorrow we will be together, this time with patients, with an interesting sociological and psychological analysis performed with experts from the University of Canberra and Cardiff, assessing similarities and differences in patients' management with advanced venous and lymphatic disease. Once again, deeply thank to the ones who have made this possible, Alpha Sigma, Medi, and Philips through their unrestricted grants to this not-for-profit initiative. Today, we virtually started from Georgia, for which we deeply thank the Georgian Association. We are now going back to Latin America, where we congratulate once again the Phlebolatan Group for their splendid initiative, never forgetting the pillars from Africa, with the particular mention of the LATAF project with Professor Wassil Lata and Professor Bishar and all the related friends. I deeply thank you, and I just say go Costa Rica for the remaining hours that you have over there. Everybody is invited to join them there. Once again, thank you so much. Sorry if it has been quite long, but surely meaningful to be together in Italy virtually today. Thank you so much. Ciao.
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 Ciao Sergio.
Grazie Sergio.
Grazie a
Saluto
voi.
a tutti, grazie.
Ciao a tutti.
Ciao Sergio.
Ciao a tutti.
Ciao Sergio, ciao a tutti.
Ciao a tutti.
Ciao, ciao.
Ciao.
Ciao, grazie a tutti.
Ciao.
Grazie, Sergio.